I'm Nick Majerus and welcome to Top Med Talk Conference Highlight. Monty, Mythen and Joff Lacey on day 2 of EBPOM 2017, speaking with Professor Sol Aronson, tenured professor at Duke University, and Dr. Mike Irwin, professor and head of the Department of Anesthesiology at the University of Hong Kong. They're speaking about patient risk. Have a listen.
Top Med Talk. So we went on later on to talk about this concept of fitness for anaesthesia, fitness for surgery, and you've alluded there to a number of factors. And in your one of your lectures, Sol, you described modifiable and non-modifiable factors, 3 broad categories of things we might be able to do something about.
Right, and I think it's a great conversation to have in lieu of this broader concept of risk and how to identify it. Certainly, it's something that we all confront every day when we choose to anesthetize a patient for a surgical procedure. Sometimes people are ready for surgery and they're ultimately healthy, and sometimes they are not. And of that subset that we would consider to be unhealthy, chronic comorbidities that are not necessarily managed well medically, the question that we have to ask ourselves, and I think we've begun to proactively ask at Duke, is I know you have to have surgery, but are you ready to have surgery? And what kind of modifiable risk factors are existing, and what can we do about that? Sometimes we're old, we have a genetic makeup that is unmodifiable, and we manage that as best we can. Sometimes we have acquired diseases like diabetes or poor glucose tolerance or anemia. And sometimes we have risk factors that are self-induced, that are lifestyle, if you will, created. We smoke, we drink, we don't exercise, for example. And I think as we begin to try to bend that risk curve and make it more favorable to make sense of the broader discussion of what we should do and what we should not do, we've engaged patients now with the attitude that if there is a modifiable risk, we want to proactively identify that as early as possible, and then send them down a care pathway where we can actively do something about it before they come to surgery. And it may be that they are not good candidates to ever come to surgery.
Yeah, so this is true. And also the other thing is the urgency of surgery as well that has to be considered also. So there are some risks which are modifiable, but it may take some time to modify that risk. And then it may be unreasonable to delay certain types of surgery. You mentioned cancer surgery, for example. So I guess it's another thing has to be factored in.
Right, unquestionably. Emergencies and urgent procedures need to be managed emergently and urgently as the conditions would dictate. And within that window, however broad or long that window is, you do what you can do. But in the instances where it's not emergent or urgent, I think we have to reorient our paradigm of what we should do and can do.
So if you just joined us, this is day 2 of the annual evidence-based perioperative medicine meeting in London, UK. This transmission is generously sponsored by EBPOM and Edwards Life Sciences. For more details of the meeting we've been attending, please go to www.ebpom.org. I'm here with Dr. Joff Lacey, Professor Sol Aronson from Duke University in the USA, and Professor Mike Irwin from Hong Kong. And we've just been discussing risk in the broadest sense and got to the very sticky point now of potentially modifiable risk factors in the build-up to surgery that might improve outcome. Now, one of the talks we heard later in the day, there was a plea went out to say, can't we get to the patients earlier? So what often happens is we go to a referral point, like our family practitioner, we start down the pathway towards possible surgery, and then our detailed evaluation is very close up against the date for surgery. Could we get there a lot earlier? Sol?
So the short answer is yes, we could. The more complex answer is how do we do that? And the motivation is that we should. The paradigm, for reasons that are complex, but certainly traditionally, is that we tend to get a chance to intersect that patient soon before their scheduled surgery, and that could be days or weeks, and that's obviously problematic.
So is there anything, I mean, I guess it could depend a little bit on your geographic situation. Like, for example, as you mentioned, the UK, we have very good primary care service in the United Kingdom. Could the general practitioners be involved in this process, for example?
I think they could, and we have to work out a way that they can find the time and have the resource to do that. They are the point of referral. The information that would help to risk stratify them are usually part of what they should be doing on a regular basis anyhow, checking our blood pressure, checking our HbA1c levels, our diabetes states, etc. on an annual basis. But we know they're under huge pressure, and they're financially very constrained, and they're very time constrained. So I think there are some pilots ongoing where there would be an expected bundle of sort of fitness for referral, it's been referred to, that would also come with some money associated with it. That means that the time and the resource was there to start that process immediately. Because if you RAG rated clearly from the point of referral, I think we all believe you'd be much better off to start that evaluation straight away.
I think that's all true, and I think we're early in the process of beginning to understand what is that practice that makes best sense. I think it's also reasonable at this early junction to appreciate the significance of the declaration of surgery that the patient has to own. And I think that motivates change in lifestyle. I think it motivates change in their abilities and willingness to take care of themselves. And I think there is something unique about the perioperative domain in that continuum of the life cycle. And though a primary care physician certainly would and could and often does the best they can to manage these patients in the chronic care sense, that when you're confronted with the reality that you are now having to have surgery or should have surgery, that's a perioperative domain. And I think there's something potentially unique and special and differentiating about having those directives be provided by the perioperative medicine physician.
And making the patient more active in their treatment as opposed to being a bystander, which has traditionally been the case.
Exactly. And I think at the end of that journey, again, to the elective, it's that they will be ready to have surgery. And if they are not ready to have surgery, they would not necessarily have surgery. So if their knee hurts, they're obviously going to be motivated to want to get their knee replaced. But if we tell them their chances of having that done without having downstream adverse events are much greater if they do A, B, and C, then that's a communication and a conversation that I think is uniquely suited to that perioperative domain.
Top Med Talk.
If you enjoyed that, why not check out our website, topmedtalk.com. Have a little look, browse, and sign up to our newsletter, topmedtalk.com.